In the last lecture segment, I talked about signs and symptoms you'd see in your patient that's developing or has developed a PE. Let's talk a little bit about medical diagnosis. Of course, the history and physicals, so it's very important that we document our assessment findings. Other things we can do: lung scan, also known as that ventilation perfusion scan that I talked about earlier in the lecture, where we can compare the ventilation to the perfusion. If the lungs are ventilating well but not perfusing, then that's a sign that there's a pulmonary embolism blocking. ABGs, a CT scan. There's another lab test called a D-dimer that sometimes is used to detect breakdown of clots and release a certain protein that the D-dimer can detect. Medical treatment is going to revolve around anticoagulation. Now, once someone has a pulmonary embolism, a clot, we really can't use any medication to break down that clot. The only time that we use clot-busting drugs is in the ER when someone's having a stroke, and we have a real narrow 3-hour window to do that. With a pulmonary embolism, it just doesn't fit that criteria. So we have to let the body break it down on its own. But we can give anticoagulants to prevent development of further clots or that clot enlarging. So here's 3 of the most common drugs that you'll see for pulmonary embolism. Lovenox is usually used as preventative. So people go on this before they develop deep vein thrombosis, and the hope is that they won't develop it because the Lovenox prevents that. Heparin is used often after a clot has already developed, and again, it's going to not break down the clot but prevent it from getting bigger or from developing more. When someone's on heparin, we're going to monitor a lab called the PTT, and we want to maintain a PTT which is a time frame of 1.5 to 2.5 times the normal. So we want this patient's blood to take twice as long as a normal person's blood to clot. And then we can also start them on oral anticoagulants, warfarin or Coumadin. And the lab that we use to monitor warfarin or Coumadin levels is called the PT/INR. They're actually 2 different labs, and we mostly use the INR, but they always are going to go together. So PT/INR will monitor your Coumadin or warfarin, and your PTT will be used to monitor the heparin. Very similar in action, although heparin's going to work a little faster. Heparin is frequently administered kind of like insulin on a sliding scale, and you'll adjust the dose based on the results of the PTT. So we'll be drawing PTTs frequently, maybe every 4 to 6 hours while the patient's receiving heparin. You'll have a little sliding scale like this, and you can adjust the rate so that this way we don't have to call the physician every single time that we do a PTT. We're given some freedom to follow this order just like we would an insulin sliding scale. You might also see a similar scale for your warfarin or Coumadin doses. And again, it's going to be based on the INR. This is a time frame that tells us, how fast the blood's clotting. And the reason that we have like 1.5 or 1.9 or 2, that's telling us that it's approximately, it takes twice as long for this person's blood to clot than an average person. Warfarin comes in lots of different dosages, and so it's pretty easy to tweak it. Just go up to the next dosage. Getting the dose just right can be a challenge, however. And we have to constantly monitor for signs and symptoms in our patient that their blood is too thin. So nosebleeds, you can see here, how it can affect the eyes. Be careful with razors and shaving and all kinds of other interventions. The last acute problem of the respiratory system that we're going to talk about before we move into the chronic problems is acute respiratory distress syndrome, often abbreviated ARDS. It is a progressive pulmonary disorder that follows some sort of trauma to the lung. So any of the things that we've been talking about can lead to ARDS. The patient that's being treated for this will typically be in the ICU. Some of the more common causes would be pneumonia that maybe goes septic, inhalation of harmful agents, or chest trauma, or maybe even head trauma, because if you recall from the very first lecture segment that the medulla of the brain controls the respiratory system, so head trauma that affects that ability to breathe can result in acute distress. It happens from 1 to 96 hours after the trauma. Pulmonary infiltrates develop and the lung compliance decreases. fluid shifts into the alveoli. Remember those microscopic little sacs where the exchange takes place, and it results in pulmonary edema. The production of surfactant decreases, which leads to atelectasis, although this is atelectasis on steroids, you might think of, in that it's more than just that basic atelectasis that often develops after surgery. This is chain reaction atelectasis that, if not corrected, will result in death. The patient's not able to exchange the oxygen or carbon dioxide across the membranes of the affected alveoli, which results in hypoxia, which is low oxygen levels, and hypercapnia, which is the high carbon dioxide. The first sign that someone is developing acute respiratory distress syndrome is going to be an increased respiratory rate, which, that can accompany a lot of different things. So that would just be our key to watch a little bit closer. Respiratory alkalosis might initially develop, although, as you can guess, when we're trapping CO2, it's going to eventually turn into respiratory acidosis, but alkalosis might develop first because of the increased respiratory rate. When we listen to the lungs, we might hear some fine crackles, again, from those collapsed or fluid-filled alveoli in a cough. The patient will become restless, agitated, maybe even confused as the oxygen levels drop, and we'll see tachycardia result as the heart attempts to compensate for the low oxygen levels by increasing circulation. These early signs are followed by progressive and worsening dyspnea with retractions. And if you don't know what retractions look like, when you're looking at somebody's chest and you can kind of see their rib cage when they inhale, that's how I think of a retraction, and we shouldn't see that. The chest should move up, not in, when someone breathes. Bronchocyanosis, which means blueness in the extremities, and even some diaphoresis as the patient struggles to continue to breathe. Diagnosis is made, again, by the history and physical, how the patient presents, history of some type of chest trauma. ABGs, again, we'd initially maybe see alkalosis, respiratory alkalosis, followed by respiratory acidosis as it progresses, a chest x-ray. And the main thing that we'll see on the ABGs is that O2. It's going to fall below 70 despite turning up the oxygen. So we keep cranking up the oxygen and it doesn't help. And of course, we already talked about when someone is below 60, they're no longer able to perfuse sufficiently, and it's an emergency. CO2 will go up, and like I said, respiratory acidosis will eventually develop. Medical treatment relies on early detection and treatment. The sooner we can treat this, the better. Usually, this patient will have to go on a ventilator so we can control better that we want to try to get them back into a little bit of an alkalotic state, so reducing that CO2. To prevent them from fighting the ventilator, usually they'll be sedated or given a paralytic. We don't want someone awake while we're ventilating them, so we put them in a semi-comatose state. Corticosteroids to reduce the inflammation, and antibiotics if sepsis was the cause. Before we move on to chronic conditions, just wanted to do a quick review of acute respiratory failure. We're talking about insufficient oxygen transported to the blood, which results in what we call hypoxia. So insufficient oxygen in the blood. Inadequate carbon dioxide is removed, which we call hypercapnia. The patient's compensatory mechanisms have failed, meaning they can no longer adequately control their pH or acid-base balance. Signs and symptoms: dyspnea and alterations in rate and breath sounds. The patient will often become restless, leading to confusion. And in later stages, you might even see a decreased level of consciousness and become drowsy. Tachycardia initially might then go to bradycardia as the condition worsens. Dysrhythmias, and which can lead to asystole, which is really, really bad. That's when we get to hit the dreaded code blue button. Initial signs and symptoms would be hypertension, again, as the body tries to compensate, but after failing to compensate after a while, we might see hypotension result as a result of shock. ABGs will reveal an oxygen less than 60, and we know that's acute respiratory failure. If it's less than 60, normal is 80 to 100, so once we go below 80, we start getting worried. Medical emergency after it drops less than 60. And the carbon dioxide, you should have memorized this by now, 35 to 45, and in acute respiratory failure, we're going to see it higher than 50. Medical treatment involves identifying and treating the cause. Rolling the head of the bed up, we want this patient in high Fowlers. If their LOC is enough that they can obey commands, encourage deep breathing, we're going to use bronchodilators to help them breathe. Oxygen supplementation, again, 1 to 5 liters, we can use nasal cannula. More than 5, we need to switch to a mask. And prepare to put the patient on a mechanical ventilator if those interventions don't seem to be enough. We'll start on chronic problems of the respiratory system now. And the first one that we're going to talk about is asthma. Asthma is a potentially reversible obstructive airway disorder characterized by airway inflammation, hyperresponsiveness, and obstruction. The term hyperresponsiveness refers to the airway being especially sensitive to stimuli. The incidence of asthma has been increasing. It occurs across the lifespan from the very young to the very old, but it's often considered a disease of childhood. It's a highly complex condition that for some is simply a mild nuisance that they don't think about except for when they're filling out their patient history, but for others it's a very serious life-threatening condition. Although the cause is unknown, it appears to be the result of both innate immunity, so things that you're born with, as well as environmental factors. Patients can have attacks of varying intensity, and there appears to be 2 distinct phases, which are labeled early and late phase. The early phase of an acute episode begins with a trigger, and a trigger can be an allergen, so if someone's allergic to tree pollen, that could be considered a trigger. An irritant, like maybe the smell of gasoline fumes. Infection, resulting from like a viral illness, maybe a cold. Exercise, gastric reflux, or stress that activates the inflammatory response. The airway then constricts and becomes edematous. Mucus secretion increases, forming plugs in the airways. Obstruction causes air to be trapped in the alveoli. So even though the alveoli are perfused with blood from the heart, the CO2 or carbon dioxide cannot get out and the fresh oxygen cannot get in. So this is kind of opposite of pulmonary embolism. Ventilation's affected and not perfusion. The effect is hypoxemia with hyperventilation. These episodes occur within 30 to 90 minutes after exposure to the trigger. Sometimes they're even more immediate than that. And then, so that's the early phase. The late phase begins 5 to 6 hours after the early response. Airway inflammation remains pronounced during this phase, which can last several hours to several days. And the airways remain hyperreactive, meaning that the patient is at higher risk for having another acute attack. So it's like their airway remains on high alert. So it takes less stimulus to trigger another asthma attack than it did even before that. Some patients are not able to identify any specific triggers, and this is called intrinsic asthma. Asthma associated with specific triggers is referred to as extrinsic asthma, and I would say most patients know of at least a few triggers. When someone continues to have severe persistent bronchospasms that's unrelieved by inhalers, this is called status asthmaticus, and if it's not corrected, it can lead to right-sided heart failure, as well as respiratory and cardiac failure. It can be really scary when somebody is having an asthma attack, both for the person experiencing the attack and the people standing by, especially if this is a child and you're their mother. I've been through that a few times. Dyspnea, meaning shortness of breath, will initially happen, as well as tachypnea, so the rate of breathing speeds up. Often a productive cough, and you'll notice use of accessory muscles. Again, the diaphragm is not really considered an accessory muscle. That's the main muscle of breathing. Everyone uses their diaphragm to breathe. But when you start seeing someone using their shoulders and neck to try to take a breath, that's called using accessory muscles, and that's an ominous sign. Audible wheezing. So wheezing is the main sound that we hear that's attached to asthma, and that's the sound of air passing through a constricted airway. And so when people with controlled asthma go in for the routine visits, that's one of the questions that they're often